فتح الرحمن الناس دول منتظرين ده.
طيب محي الدين. Are you
رسلهم
ready?
الجروب.
Yeah, عرفت
Okay.
الرحمن.
Scenario: a 56 years old man presents with right knee pain that's been worsening after previous knee surgery. You have 6 minutes to take a focus history and 3 minutes for discussion.
Okay.
Okay, let me put the timer.
Muhammad, you will be his patient, okay?
Okay.
Okay, my name is Muhammad.
No, let me put the timer. Wait, please. Yes, 6 minutes started.
My name is Muhammad, one of the surgical doctor here. Can I confirm your name and date of birth, please?
Hello, doctor. My name is Jack and I am 9066.
So I'm going to ask you a few questions regarding your condition today. Is that okay with you?
Yeah, that's fine, doctor.
So how can I help you today?
Oh, doctor, I'm sorry. I have this pain in my right knee.
I'm so sorry to hear that. So do you want for me to offer you a painkiller if you want?
Yeah, I'm okay with that.
So does it move anywhere, this pain?
No, it's constantly in my right knee.
Uh, did it start suddenly or gradually?
Gradually, doctor.
Does it come and go?
Initially, yes, but now it is persistent.
Has it changed recently?
Yes, it's getting worse.
Okay, can you describe the pain, please?
How can I describe it?
Is it thrombin, achy, or
Yes, it's
constant?
deep achy pain and sometimes sharp.
So anything make it relief, or anything you can do that
Yeah,
make you feel better?
resting.
Anything make it worse?
Yes, exercise.
And how does it affect your daily life?
Very challenging, doctor. I'm suffering to climb the stairs.
Difficult to climb the stair.
Yeah,
Okay, I'm so sorry to hear that. So on the scale from 0 to 10, 0 is 0 no pain, 10 is worse. How can you describe this pain?
7.
Okay. Did you notice um, any noises when you while you're walking?
Again, please.
Did you notice any noises when you while you're walking?
Yes, doctor. In my right knee specifically.
Is there any change in your knee shape?
Yes. Been bigger than your normal, doctor.
Um, have you had any previous trauma in your knee?
Yes, I fell 3 years ago and I underwent surgery in my right knee.
Okay. Did you experience your knee going away while you're walking?
No, I didn't experience that.
Um, and did you experience locking in your knee?
No.
And have you noticed stiffness during the morning or when you woke up?
Stiffness in my knee? No. But sometimes I feel stiff. I feel stiffness in my knee.
Okay, I'm so sorry. Do you have fever?
No.
You said that your knee has been changed to be like
Big in shape, yeah.
swelling,
Yes.
big in shape. And have you noticed any discharge from your knee?
No.
Any change in color, like
No.
redness or?
Yeah. I think there is redness in my right knee.
Okay. Uh, any weakness?
Weakness where? In my legs?
weakness or numbness in your legs?
No.
Any back pain?
No, I didn't experience any back pain.
Rash anywhere in your body?
No.
Any change in your bowel habit?
No, doctor.
Thank you for sharing this information. Did you experience any similar condition in the past?
Similar condition, no, just that trauma I experienced 3 years ago and that surgery, doctor.
Almost 3 years ago.
Yeah.
Unfortunately, to hear that. Do you have any medical condition rather than your knee pain?
I'm not aware by anything regarding this pain in my right knee.
Muhammad Habibi is asking to join in. I'm not sure if she joined here. Just continue. Check from your side. Yeah, continue.
Say again, sorry.
Continue, Muhi.
Is there any family history of similar condition? Do you have
I'm,
anyone in your family experience the same thing?
I'm not aware by anyone, doctor.
Is there any history of hospitalization or
Yeah,
surgeries?
yeah, that's surgery, as I said previously. But doctor, I'm not aware the type of surgery that did in my knee.
Okay. Is it surgery followed your
Yes.
incidents that you had the trauma?
Yeah, after falling, yeah.
Oh, the days after or
At the same
the
day.
trauma?
At the same day.
The same day.
Yeah.
Okay. I'm so sorry to hear that. And are you allergic to any kind of drug?
I have no any allergies. Time up.
Are you?
Time up. Could you please present your case?
I'm presenting this gentleman, a 53 years old, who presenting with knee pain. Follow it. He has a history of trauma 3 years ago, which is it end up by a surgery. This pain is interacting with his life by stiffness during the morning. That's it.
So what's your main differential diagnosis?
Osteoarthritis.
Osteoarthritis. What other differential diagnosis you would consider?
Anterior cruciate ligament or meniscus tear, septic arthritis.
Anterior cruciate ligament just, or you mean anterior cruciate ligament injury?
Anterior cruciate ligament injury.
What else?
Tear. Meniscus tear.
What else?
Septic arthritis.
Yeah, that's enough. How to approach this patient?
I will manage him by conservative management, by give him analgesia, paracetamol, and non-steroid anti-inflammatory disease, physiotherapy, and weight reduction. For the intervention, or for intervention, I can give him intra-articular corticosteroid.
Intra-articular steroid injection.
Yeah.
Yeah. What about the operative management?
If that is not working, if he didn't get benefit from the conservative and medical treatment in the intervention, I will consult the orthopedist, the surgeon, to do total or partial knee replacement.
So, doctor, will he return to playing football 9 months after surgery?
No, unfortunately.
This is the last question in this session. Very nice, Muhyiddin. Ali, do you like to start?
Yeah, good, Muhyiddin. Very good presentation. It's an easy session, to be honest. It's not a difficult one. Your English and how you approach your patient was fantastic. And as I said, we're not going to mention the positive. We're just going to mention the negatives for you, okay?
Okay, go ahead.
So don't be disencouraged by the way we attack you in a way. Okay. You introduce yourself and you took permission, but I think the introduction has to be more clear. Let's just repeat it, me and you again quickly. You are the doctor, I'm the patient. Can you just get the part of the introduction?
Hello, my name is Muhammad, one of the
You didn't
surgical
say hello
doctors.
at the beginning.
Okay,
Oh,
fine,
my
fine.
session, yeah.
Let him do it, Muhammad. Okay?
Yeah.
Do it again.
Hello, my name is Muhammad, one of the surgical doctor here. Can I confirm your name and date of birth, please?
Hi, doctor. My name is John. I'm 55-year-old.
5 years old. I'm going to be your doctor today. Is that
Okay,
okay?
yeah, okay. So that's not wrong. Okay, continue. I'm going to be your doctor. Okay, doctor, that's fine. Yeah.
Okay, so we're going to start by asking you a few questions, if you don't mind, regarding your condition.
Yeah, I don't mind. That's fine. Okay, now you played it better than earlier. So hello, my name is John. Hello, my name is Muhyiddin. I'm one of the doctors working here. May I confirm your name and age? You can say date of birth. That's fine. It's not wrong. May I confirm your name and age? Yes, my name is John. I'm 55-year-old. Today I will be your doctor. Are you okay with that? So when I tell you I'm John, I'm 45-year-old, you can say, nice to meet you, Mr. John.
Yes.
Okay.
Yeah, nice to meet you, Mr. John. You didn't say that. You didn't say it at the start, and you didn't say now. Even now, you didn't say it. You just immediately dropped the bomb and said, I will be your doctor. Okay? So when I tell you my name is Ali, I'm 55-year-old, you should say, nice to meet you, Mr. Ali. Today I will be your doctor. Are you happy with that? Are you okay with that? You need to confirm with me that I'm giving you a consent. Maybe I don't want to see your face. So you should make it very clear. Are you okay with that? So you get the mark of the consent. There's two marks in the consent. So you have to make it very clear you took the consent from your patient. You did take a consent, but it was a vague consent, ambiguous consent. You should make it very clear. Are you happy with that? Are you okay with that? I want you also, while you're practicing, to add more energy. I don't want you to practice like you are reading a newspaper, Muhyiddin. I want more facial expression. I want a clear voice. I want you you don't say like this like you bored. Like you have a yeah, I know. That's why we're treating this one as the exam. It's just like me as examiner seeing you, I will think you are hypothyroidic. So you have to be very energetic, like what I'm doing now. You have to be, you change your facial expression. Yeah, Mr. John, nice to meet you. And don't forget your exam in UK. So you have to play this way. Okay?
I think if you
yeah, let me finish my points and then we'll let you say your points quickly. So you have to add more energy. You have to play with your tone. So if I tell you I have this severe pain, you didn't say I'm sorry, Mr. John. I'm really sorry, Mr. John, for the pain. Okay? And when you offered me painkiller, instead of saying, would you like me to offer you painkiller, you can say, do you want painkiller? Let's get to the bottom of it. Because if maybe I want, the question is not wrong, but it's not the accurate question. You said, would you like me to offer you painkiller? That's not a wrong sentence, but the more accurate sentence is, would you like some painkiller? That's it. Instead, you offer or not offer. Would you like some painkiller? So you got to the bottom of it. And did you? You said, did you notice any noises? I'm not sure, Muhammad. What did we say in school exactly? I don't think noises is the best sentence to say.
Noise is the right one.
Yeah, any grinding or noises when you're moving. Yeah. So grinding or noises. Both of them.
Crepitus, yeah.
Yeah, crepitus, which grinding or noises. You pronounce. Can you say the word followed? Followed for me.
Followed.
Sorry.
You said followed though. Which word?
Yeah, Followed. How you pronounce this word?
Followed?
Followed, yeah. I think you said follow it or something like that. You emphasize on the ED. We have the recording. I know you're surprised, but the way you pronounced it, you said
I'm not
follow it.
surprised. I just
Yeah,
remember.
you said follow it instead of followed. You will be followed. It's not you will be follow it or you will be followed. In your presentation, I don't want you to put your hand in your ear like this, and I don't want you to put your pen like this. Keep your hands down while you're presenting. Like, don't present to your examiner like this. I took a clinical history from John. Yeah, that's what we did. That's what you did. And look to the recording later on. So don't present your patient like this, like you're having a headache. Just present while your hands are down. I'm just going to quickly go through the differential. You differentiate osteoarthritis. You asked about injury for ACL and meniscus. I'm not sure if you asked about the stiffness in the morning.
Yes.
Muhammad,
Yeah, he asked me about the stiffness.
stiffness. And did you ask about any fever?
Yes, excluded,
He
yeah.
asked about the fever, fine. Did he ask about rash and bowel habits?
Yes, he did.
Fine. And weight loss, he asked about it, right?
I know.
Yeah, weight loss for malignancy. This patient will not have osteosarcoma, of course, but you just need to ask about the. You need to ask about the.
Weight loss.
You need to ask about the thingy, what they call it. I forgot what it. You need to differentiate any weight loss. Okay. So overall, I would say if you just change the tone, if you became a bit more energetic, this will improve your performance hugely. You don't have a big problem with the grammar. You don't have a problem with the discussion. I think you just need to
I need to
present
talk about
better.
the discussion, yes.
Yeah, you need to present better and faster. Yes, Mohammed? But overall, that's an excellent performance, Muhyiddin.
Yeah.
Okay?
Yeah.
That's pass, of course, Muhyiddin. Very nice presentation. I think Ali covered all the points, but regarding the first point we mentioned yesterday, which is, could you tell me more about it? You should start by an open question because this is professionalism. The other thing regarding discussion, as Ali said, you need to manage the discussion. You should mention firstly the main complaint, then 2 to 3 points regarding the history of presenting illness of this main complaint. Then 2 to 3 points regarding noises in his right knee to support the osteoarthritis. Jump immediately. So my main differential diagnosis is KIDA, and also I would like to consider blah blah blah. Don't let the examiner ask you what's your main differential diagnosis because it will take 10 seconds. Okay. Other thing, when I asked you how to approach this patient, you forgot to mention the examination and investigation. After taking this full history, I will consider to do full clinical examination, right knee joint examination. And also I would like to order investigation, blood investigation, lab, imaging, lab. The crucial things to mention the investigation, specifically the imaging. Otherwise, you answered all questions correctly. Very nice.
I just want to double check. Did he say what?
No, he forgot to mention all the investigations.
Okay. Your examiner, if your examiner asks you about the investigation, that's fine. But some examiner will say how to approach the patient. By how to approach the patient, Muhyiddin, that mean the investigation,
the examination and the treatment, yeah.
And the treatment. So some examiner will say what's your investigation specifically. Okay. So the most important investigation here is weight-bearing X-ray, MRI of the knee, and then the blood test, full blood count, CRB, and ESR. Okay. If the joint is swollen and you're suspecting septic arthritis, in this case, you will do joint aspiration for calcium and sensitivity. Okay.
Okay.
Very nice presentation.
That's a good performance.
Yeah. Should we go to the next session?
You said you have he said he want to say something. What do you want to say?
I want to say that I'm so glad to join this performance, to do it or to practice it, because I thought myself I'm ready to go to take the history straight away on the exam, But I found myself I couldn't remember anything about what you have said. Yeah.
Yes, to be honest,
Muhammad,
yeah,
I forget anything. I forget even I couldn't build even any single question. I was suffering to build the question during
Muhyiddin, I have 6 people who contacted me after they watched the YouTube videos and our previous course, and their exam, unfortunately, in August, start of the August, and they didn't even practice once. Okay, and they discovered very late that they need to practice the communication, unfortunately, and the skills. I said, I couldn't even add them to this course. So starting with the skills is a very good advantage for everyone, because people underestimate. They will say, "Yeah, communication skills is easy. I'm just gonna go there and answer all the question." And you will notice when we come to the communication, how difficult is it, unless you practice.
It's really difficult. I forget the name. I forget the main component of the.
All right. Good.
You will monitor this by practice, Muhyiddin. Don't worry.
Okay, so let's move to the next, Muhammad Habiba.
Sorry, Dr. Ali, Dr. Muhammad.
Yeah.
I just have a point. He did well, really, but he apologized too much.
That's not a negative. Umar, Muhammad, Akasha.
Yeah, but he's wasting time. I think it's one more time or two more time is enough. But he apologized more.
Do you know when I do apologize, I was trying at that time to remember that which the next step. This is why
you are wasting time.
You will notice, Muhyiddin, but by practicing more and more at the end of the course, that your performance is way much better than the start. That's why we do this recording, so you can compare the first station you did and the last station you did. Okay.
I have a question.
Okay.
Yes, Omar.
Sorry. In differential diagnosis, why we mention it specifically anterior cruciate, not posterior, or why we didn't say cruciate ligament? Yes.
Anterior cruciate ligament is most common than posterior cruciate ligament injury.
Umar, I work in trauma and orthopedic. Okay. And I see every single day I see patients coming to the hospital. I've been here for last year. I didn't see a single posterior cruciate ligament. It's very difficult. But it's just ACL is more common with the trauma. That's the main pathology, unless you have osteosarcoma or if you have a specific problem. So that's why it's more important than the posterior cruciate ligament.
Okay.
Yeah, but even if you are right, posterior cruciate ligament is also a differential, but it doesn't fit the scenario. And you don't want to waste your time because your patient is going to be either osteoarthritis or rheumatoid arthritis. It's going to be osteoarthritis 99%. Okay?
Yes. Yeah. So the next station is back pain. Habiba, are you ready?
Yes.
Okay, scenario. A 45 years old man present with lower back pain.
Habiba, you have no problem with recording this session, right? You already.
No, I don't have a problem. Yeah, it's okay.
Fine. Okay.
Okay, the scenario: a 45-year-old man present with lower back pain. You have 6 minutes for focus history and 3 minutes for discussion. Okay.
Okay.
Let me put the timer.
I can be the patient, Muhammad. You want to guide her to a specific diagnosis.
Okay. 6 minutes started.
Okay. Hello, my name is Habiba. I'm one of the surgical doctors here. Can I have your name and age, please?
Hi, doctor. Yes, my name is John. I'm 55 years old.
Okay. I'm happy to... Hello, Mr. John. I'm gonna be your doctor for today. Is that okay with you?
Yeah, that's totally fine, doctor.
Okay. Can you tell me how can I help you today?
Yes, I have this back pain, doctor. I really want to get rid of it. I wish if you can help.
Okay. Is this pain, can you tell me more about it?
Yes. So it's not new, doctor. It has been here it's been there for years. But in the last 4 or 5 days, it's becoming very worse.
It's becoming
Okay.
bad, intolerable.
Okay. Is it gradual or it's sudden onset?
It's gradual.
So it's continuous or comes or come and goes?
It's continuous, but it does increase when I'm active.
Does anything else increase it?
Yes, if I lift any heavy stuff or if I stop taking my ibuprofen, all of this will lead to more pain.
Does anything else relieve it?
Painkillers and rest, yeah, does relieve it.
Can you describe the character of the pain?
It's just numbing pain around my back, and yes, it's like how should I say it? It's not like a stabbing pain. It's just like a normal pain of the back. To be honest, I don't have a specific criteria for it.
So does it radiate to anywhere else?
It doesn't radiate to anywhere else, but sometimes I will have some pain around my legs also. But I don't think that's a radiation.
The pain in the leg comes with the pain in the back?
Sometimes, yeah.
Okay. Does it affect your life?
To be honest, I'm working fine. It's just like I'm not happy through the day because of the pain. That's it.
Okay. From 1 to 10, 10 is the worst. Can you tell me how bad the pain is?
Around 7, 6 to 7.
I'm sorry for that, Mr. John. Okay. Do you have any trauma lately?
No, I don't have any trauma now.
Okay. Do you carry heavy objects?
Yeah, I work in a warehouse. That's why I work in Amazon. So I do carry heavy stuff.
Okay. Do you feel like you have weakness in your legs?
No weakness, no. No weakness.
Do you have numbness?
No numbness
your
at all.
leg?
No.
What about the anal area?
Yeah, what do you mean?
Do you have numbness in the anal area?
No. It's completely fine. Yeah.
Do you feel like you have a problem in controlling bowel movement or urinary
No,
movement?
my bowel habits are normal, to be honest. There's nothing going on there.
Do you have problem with the erection?
No, I'm completely normal.
Okay. Do you feel like you lost weight in the past few years or few months?
I lost weight, but I'm on diet, doctor.
Okay, so it's an intentional weight loss.
Yes, it's intentional, yeah.
Do you have fever or cough?
No, I don't have cough or fever now.
Okay. Can I do you have any diseases?
I have diabetes and I have hypertension.
So do you have any similar conditions like this one?
What do you mean similar condition? I just have this back pain which is going on for years, as I said.
For years, yes.
Yeah.
And do you take any medications?
Yeah, I take metformin and lisinopril.
Okay. And did you do any surgeries before?
No. I didn't do any surgery before, no.
Do you have any allergies?
No, I don't have any allergies.
Does your family have any similar conditions?
You mean back pain?
Yeah.
Yes, my dad has some back pain. Yes.
Do you mind if I ask you some personal questions, Mr. Jordan?
No, I don't mind, doctor. You can carry on.
Okay. You told me you work in a warehouse, right?
Yeah, I do.
Okay. Does anyone live with you?
Yeah, I live with my wife and I have 2 kids.
Okay. Do you have problem climbing the stairs?
I don't have problem with the stairs. It's painful, but I can manage.
Okay. Do you smoke?
No.
Do you drink?
Time up. Could you please present your case?
Okay. My patient is Mr. John. He is 55 years old. He had big back pain for several years, and in the past few months, the pain increased. He worked at a warehouse, and this pain doesn't necessarily coordinate with leg pain, and he doesn't have leg numbness, doesn't have any neurological symptoms. He doesn't have weight loss or cough or fever or okay.
Yeah,
Doesn't
from
have-
what you said, what's your main differential diagnosis?
My main differential diagnosis is mechanical back pain.
And what other differential diagnosis you would consider?
Okay, it could be it could be mechanical muscle strain. It could be neurological, like coda It could be metastatic. It could be and TB back
Yeah.
TB spine.
Yeah, that's enough, doctor. How to manage this patient?
Okay, for but after I took the full history, I need to do a full clinical examination, and in the investigation, I want to do blood investigation, like full blood count, C-reactive protein, urea and electrolyte, and for the imaging, I want to do X-ray, MRI, and
What type of X-ray you will request?
I don't remember.
Okay, continue.
Okay. For the management, I need to do. I need to give them NSAID. I want to give NSAID on our paracetamol and physiotherapy, and I could refer him also for a social worker. I don't know what. Okay.
Yeah, that's enough, doctor. If your patient have cord compression or coda eguina syndrome, what's your management?
First, I need to involve the neurological team. I want to do surgical decompression, and forget.
Okay, you still have time. You
And
can
if it is malignancy, what's your management?
Okay, if it's malignancy, I also need to involve the malignancy doctor or the. I'm مش عارفة أتكلم ثواني.
Time up.
Okay.
Okay. No worries. Good, Habiba. So I'm glad your exam in November, so you still have a lot of time. This is a good performance. There's some points that we need to work on. And imagine those who are their exam in August, if they went to the exam without any practice. Do you see how exam is difficult? When we put 6 minutes and then we put 3 minutes.
Yes.
Everything will change, and your stress on the exam gonna be way more than this.
Yeah, of course.
Because you know you are not in the exam now, but still you are very stressed, and I'm sure that your original performance is way better than this, but you are stressed. Okay. So one technique I will give to everyone not to de-stress. Think about it like this. It's not a fight or flight. If you didn't pass your exam, you're not gonna die, you're not gonna lose your job, you're not gonna be ugly, nothing bad will happen to you. You will just work, collect more money, and take the next exam. So there is no reason to stress. And me and Muhammad, when we went to the exam, we went with the idea that we already failed.
Yeah.
We already failed, we went for experience, okay? And I want you to think this way, Habiba saying, you're gonna pass, don't worry. With us, you're gonna pass.
Yeah, I understand. Think about the worst.
Yes, I want you to think about you are coming to the station. If I didn't say anything, I'm not here to judge you, Muhammad. Not here to judge you. You are very stressed, Habiba. You are the most stressed person here, so you shouldn't be stressed. There's nothing for you to be stressed about. We are just having a game and a discussion, trying to practice with each other, and think about this same way with the exam. So during your start, I'm not going to mention the positives, but I'm going to mention the negative. I think you mentioned all the differential diagnoses. Introduce yourself. You took permission. You already get marked for this one, but you said, "Can I have your name and age?" When you say, "Can I have your name and age?" that means you want to take my name to you. You want to call yourself Ali. When you say, "Can I have your name?" Can I confirm your name and age? As we said it in the school. It's not can I have. That's why we asking everyone to remember, to memorize the first 4 sentences. Hello, my name is Muhyiddin. My name is Habiba. My name is Subhan Rahman. My name is Muhammad Siddiq. My name is Omar Al Farouk. I'm one of the doctors working here. May I confirm your name and age? I wanted to say this like 100 times. So it became like you're driving a car. So it's not can I have your name. Okay? I was thinking that you're not gonna ask for code equine. I'm so glad, I'm so relieved that you asked about the differential diagnosis of code equine. If you miss the differential of code equine in a back pain patient, you're gonna fail the station. But luckily, you asked about the code equine. There's a small differential that you forgot. For example, you didn't ask about the night sweat. Yeah, the small tips. This will not make you fail the exam. If you ask about the fever and you ask about the cough, but you didn't ask about the night sweat, that will not make you fail the station because you already differentiated the TB. You already asked about some of the questions of the TB. For example, when we come to the IBS, Irritable Bowel Syndrome, or inflammatory bowel disease, you don't need to ask about every single one. But if you ask about 4 or 3, 5, that should be fine. I'm not sure if you asked about the family history. The time didn't allow you. And one of the main reasons that the time didn't allow you, if I calculated for you the time you said, it will be 1 minute. Or 1 minute and a half. That's a lot of time, Habiba. No, You can do what Muhammad Akash, what Muhyiddin did by saying, "I'm really sorry, Mr. John," or trying to open anything with your patient till you remember. Or stay silent. But don't say, You need to get rid of this as soon as possible. Okay? So see this recording later on, give feedback to yourself, and see exactly what the mistake you've done. Okay? You shouldn't say, There's no You sentence after sentence. During your presentation, because you're stressed, you said he has this back pain for the last few months, for the last years, and it's been exaggerating in the last few months. So I told you it's the last 5 days. It's not the last 5 months. So I have this back pain for 5 years, but you presented it as month. If your examiner is someone who's obsessive, he will not let this slide. But if he's someone who can let this go, I don't think this will affect your mark much. When Muhammad asked you about your differential, you didn't say. You said TB is fine, but it's better to say Bot's disease, as you know.
Yeah.
Yeah, and then you even forget the oncology. You said I will refer to the cancer team because you are because you are stressed. You couldn't even figure out the word oncology.
Yes, sir.
So stress is the biggest devil, and it's the shaitan for this exam. You shouldn't be stressed.
Sir.
You are working already, right?
Yeah, right.
Okay. So will you lose your job?
No.
No. Fine. That's it. And you can work extra months to get the money back for the exam. So you no need to be stressed. Okay. On your investigation, I think I'm not gonna judge you now, but you need to memorize, especially the things that you shouldn't forget. Investigation, you should say lumbosacral X-ray, not just X-ray.
Yes, lumbosacral. Yes.
Yeah, urgent MRI spine if cord compression or code equine suspected. DEXA scan, chest X-ray, and quantiferon TB if TB is suspected. Also the CRP, liver function test, and the referral also. You should say exactly, I will refer to the oncology team. So on your presentation, that's why we ask everyone to present, because think about it. And this is not just for you, this is for everyone. Some examiners will not even attend while you're taking the history. They will say, take history from this patient, okay? And they will be sitting in their table, waiting for the 6 minutes. They will wait for you to come. Imagine you are the candidate number 15. They already followed 16. They already saw 15 candidates before you. So some examiners will get tired. They will sit in the table like this. They will take history from this patient and come back. When you come back, the first interaction between you and your examiner is your presentation. That's why the presentation is very important. That's why we wrote it in the school. I took history from Mr. Jack, 45-year-old warehouse worker, presenting with lower back pain for 1 month. The pain is dull, comes and goes. This interaction, this first 10 seconds between you and your examiner will determine how the examiner sees you, and then how much mark will give you.
Yes.
Okay? You may be very nice to your patient. You may be very supportive. Your tone was completely fine with your patient. And your patient didn't see, your examiner didn't see any of this. You come to your examiner, you stutter, you don't know what to say. He will say, no, I'm not going to pass him. Okay? So presentation is very important. You have to present, you have to memorize how to present.
Yes.
Like memorization. And you have to train yourself to present according to your situation. And during this course till we finish, we will ask you to present every single history and also every single examination we come across. So if you open a school now, every single examination has a presentation part to it. Okay? Present your patient in the history and present your patient in the examination. I don't think there's any resource that put it this way. They just give you some questions that you need to ask, and you come to the exam, and your examiner gives you on your head. But you need to. I don't want to talk too much. You should be less stressed. I want you to memorize more, and I want you to get rid of the and try to speak fast. Okay, Mohammed.
Doctor, can I ask about something? About the niqab itself. Is it gonna be effective? I don't mind in the exam to wear a mask.
Look, what? Okay, where is your exam?
Please.
Alexandria, Egypt.
Egypt.
Yes.
I need to ask, and you need to ask those who took the exam before.
It's not allowed, Ali, to take any device in your exam. It's not allowed to take any device. It's not allowed.
It's not allowed.
To take
Unfortunately.
Not allowed what, Muhammad?
To take any device.
No, she said niqab, Muhammad.
Also, Dr. Ali is not allowed.
Even the face mask?
Assalamu alaikum.
Yes, it's not allowed.
I think the mask is permitted.
No, really, doctor. Even the mask is
No.
not permitted.
I sit last year for exam, and one of candidate wearing a mask, she explained to the supervisor, because there is they will come to discuss before the exam 1 minute, 5 minutes with the supervisor of the center, and she asked him, and she said, okay.
So what I would say, I'm gonna ask for you, and you need to ask those who took the exam in the Egypt, specifically about this point. And if it's not allowed, put a mask, a very a long mask, and put your head cover like this, like you ممكن تخطي طرحتك لحد هنا والماسك لحد هنا. It's a niqab basically. And at the same time, if they ask you why, I'm not sure if you have asthma or anything, just say I have allergy or whatever. I cannot, I need to be protected, or say I have
flow symptom to protect the patient.
Yes, flows.
Dr. Ali, sorry, if you say flows, they will not allow her to take it.
Yeah, that's what I was about to say. Don't say flow. Say I have an elderly family. Of course, you have someone who's elderly in your family. You are not lying by saying that. I have an elderly one, and I just need to protect them, so that's why I'm wearing the mask. Okay?
Okay.
If it's not allowed. But I don't wanna. We will discuss this later on. We will ask, and then we have another conversation. Muhammad, I don't wanna get lost of track. Your points, please.
Yeah, I think you covered all the point for Habiba. Very nice presentation, Habiba. The only thing I would like to add, don't forget to ask about the eyes. If you get it from this maybe you have a time to ask about the idea, concern, and expectation. The other thing I would like to mention regarding the investigation, when you say the X-ray, you should mention lumbosacral X-ray. And the last point, mention the patient name couple of times. Yeah, to build a rapport between you and your patient. Otherwise, very nice presentation.
This is very important, Muhammad. I just need to emphasize on your point. Please mention your patient name. Please mention your patient name. Yeah, Mr. Jack. Tell me, Mr. Jack. How are you, Mr. Jack? Tell me about your family history, Mr. Jack. Mention your patient name.
Yeah, Ali, also there is the other point regarding the questioning. Habiba, don't ask two questions at the same time. Don't ask your patient,
Okay.
do you have any fever or cough?
Okay, okay.
Yeah, do you have a fever? Any cough? Like this.
Yes, and as Muhammad said, eyes. If you have time to eyes and systemic review, if you get rid of this and you spoke faster, you will have time for systemic review and eyes. Okay.
Yeah.
Okay.
So the last
Okay.
session.
Rahman.
Is it
Rahman,
Sorry,
did you
I have asked question.
I think I will not. Cannot do it because I'm waiting for call from OR now.
Okay, fine. Then Umar Al Farouk, take this station and leave your question for tomorrow if you prepare for it, or leave your question after the station.
Okay.
So the last
Okay.
session, Ali, is hematuria, I think. Let me check.
IBS.
Muhammad Janat is already here, right?
Yes, I am here.
Yes, we're gonna start with you in the next session.
Yeah, sure. Okay.
IBS, yes. Irritable Bowel Syndrome. Umar, are you ready?
For what? IBS or hematuria?
IBS.
I think
Ali,
Hematuria
check it
tomorrow,
from
I
the
think.
school. Check it.
I
No,
think it's-
IBS hematuria on Friday.
Yeah. Today we have
So-
just 3 stations.
Yeah.
Yeah.
So I'm not Omar. Did you prepare for IBS? You can
Ali,
take tomorrow hematuria.
we will follow the schedule, Ali.
I know. We're gonna follow the schedule. I'm just checking with him.
IBS.
Did you prepare?
Yes.
Did you prepare for irritable bowel syndrome?
No problem.
Okay, so let's start, Muhammad.
So the scenario, you will be the patient for Umar, right?
Yes, I can
So
be the
the
patient.
scenario, Umar, is a 46 years old woman is referred by her GP with chronic cholecystitis. You have 6 minutes to take focus history and 3 minutes for discussion. Let me put the timer.
Say the scenario again, Muhammad, please.
Yes, a 46 years old woman referred by her GP with a chronic cholecystitis. You have 6 minutes to take a focus history. The GP suspected chronic cholecystitis, Ali.
Okay.
Okay. 6 minutes started.
Hello, I'm Dr. Omar, one of the surgical doctor here. Can I confirm your name and your age?
Hi, doctor. My name is Susan. I'm 46-year-old.
Hi, Miss Susan. Nice to meet you. I will be your doctor today. Is that okay with you?
Yeah, that's fine. Yeah.
Okay. Can you tell me, please, how can I help you today?
I have this belly pain, doctor, and my GP was suspecting it could be a dangerous diagnosis. I don't remember what did he say. And he said I should come and check with you guys here.
Oh, I'm really sorry to hear that, Miss Susan. Okay, can you tell me more about that?
Yeah, this pain, it's been there for months, doctor, and it's all over my stomach. I think it started 9 months ago, but it's getting gradually worse.
Okay, so sorry for that. Now you mentioned it started 9 months ago and gradually. Okay.
Yeah.
Anything make it better or make it worse?
When I pass stool and I go to the toilet, I feel some relief. And when I eat, especially seasoned food, the pain becomes more than usual.
When you eat what?
Seasoned food, chili food.
Chili food. Oh,
Yeah.
okay. Thank you for telling me that. Okay. Is the pain is radiating to any other area?
No.
Okay. It's getting okay, from 1 to 10 on severity scale. How you
Yeah.
give the pain? How much you give?
I would say it's differ, but it's between 6 to 8.
6 to 8.
Yeah.
Okay, so sorry for that. Did you want to give you any painkiller?
I'm fine now, but if you were discharging me today, I would like some painkillers later on. Yeah.
Okay. Do you notice any mouth ulcer recently?
Say that again, sorry, doctor.
Did you notice any mouth ulcer recently?
No.
Any fever?
No, I don't have any fever.
Any skin problem or joint pain?
No.
Okay. Is it getting worse with stress?
Yes, it does. With the stress, yeah, it's way worse.
Okay. You have stress on social life or on work?
I have I'm a business woman and I have a very stressful social life, yeah. And when I approach a project, the pain is way more than normal.
Okay. Do you have any bloating?
Yes, I do.
Okay. Okay. Do you have any vomiting or?
No, I don't have any vomiting. Completely fine.
No vomiting?
No.
Okay. No tummy pain.
No, I don't have any tummy pain, no.
No mucus on the stool or?
I don't have mucus, no, but as I said, the pain is better when I go to the toilet. I get relief by going to the toilet.
Okay. No problem. Do you have any past medical history, chronic condition like diabetes, hypertension, thyroid?
I have gallstones, doctor, and they treated me before with antibiotic, and they said they may do a surgery later on, but they didn't do any surgery.
You don't have any history of surgical procedure?
No.
Or hospitalization?
No, I don't have. I wasn't hospitalized before. No, doctor.
Okay. Do you have any chronic medication?
No, I'm completely healthy from this side. No.
Do you take any recent medication?
You asked me twice, doctor. I already said I
No,
don't take
not
any
chronic. Recently, do you have any medication recently you took it?
No, if I don't take medication for long, that means I don't take medication recently. I don't have any medication.
Okay. Do you have any allergies?
No. Luckily, I don't have any allergies. No.
Do you have any family history of similar condition?
Belly pain, no. My mom had also gallstones, to be honest, but she used to have it was removed immediately 1 month from the diagnosis, and I'm very confused. Why didn't they remove my gallstone? To be honest,
Sorry, can you repeat it?
I don't understand why didn't they remove my gallstone. They said I
You-
don't need surgery at the moment.
I didn't understand you. Can you repeat it again?
I don't understand why they didn't remove my gallstones. I told you earlier I have gallstones, right? But they didn't do any surgery for it.
Can you tell me why you think that?
I think
Imam, could you please present your case?
Yeah.
Okay. 35 years old, female, known cholecystitis. I presented with stomach pain 9 months ago. It is getting worse recently. It's aggravating by juicy food and relieving by passing stool. She reported have stressful social life. She also have a family history of the same condition. Her mom is known of cholecystitis also. Also, she reported she planning for surgery, but did not. She didn't do that.
So what's your main differential diagnosis, doctor?
Chronic cholecystitis.
Chronic cholecystitis. What other differential diagnosis you will consider?
Irritable bowel disease, inflammatory bowel syndrome, gastroenteritis.
Yeah. And how would you investigate her?
Investigate. I will start with blood test, imaging, and other tests. Blood, I will apply for CBC, ESR, and urea and electrolyte.
What other
For
tests you would
imaging,
like to Okay, continue.
Imaging, I will apply it for abdominal ultrasound, also for abdominal X-ray.
What else?
Maybe CT scan, abdominal CT scan if suspected other disease.
Okay.
Like cancer or NECA.
How would you manage her?
After full history, I will start with full examination, abdominal examination. After that, I will discuss her condition with the senior and result of investigation.
Okay, and what the treatment exactly for this condition?
First, I will start with painkiller. This is conservative treatment.
Okay, painkiller. What else?
Advice, lifestyle advice to avoid including her diet, her
time up, but
weight
continue.
and lifestyle. Antibiotic.
Okay, and what the treatment exactly besides this conservative treatment?
Surgical treatment. We will remove the gallbladder.
Yeah, this is the last question. This station very nice, Omar.
Ahmed, can I start quickly?
Yeah,
Let me
you
start.
can.
Good, Omar. Obviously, you didn't still study it from school. That's totally understandable. You just the guest cedric when you took the station, which is very good. We like this type of behavior. We like to practice even if you didn't study. That will give you that will be you will test yourself like you are in a real exam. But you missed the diagnosis, Omar. The lady had gallbladder. The GP referred her to you, but the diagnosis is not acute cholecystitis. The diagnosis is irritable bowel syndrome. Why? Because I told you the pain is around my stomach. I got relief by going to the toilet. The pain doesn't radiate to my right shoulder, or the pain is not on my right side. I don't have any MRCS sign. My pain doesn't increase when I take a deep breath. So she has biliary colic, or she has gallstones, but this is not symptomatic. She was referred by the GP. I know the scenario is very confusing. She was referred by her GP as acute cholecystitis. But when you took a history from your patient, you should come to the realization that this lady has no acute cholecystitis, and the gallstone basically is not the problem. She has no jaundice recently. She has no fever. The pain is around the stomach. The pain gets relieved by going to the toilet. So that's more toward irritable bowel syndrome.
Ali, you know
Yes.
why he said acute cholecystitis? Because he didn't exclude it from the differential diagnosis.
Yes, that's what I'm gonna say now. The next because
I'm not excluded. I remember you said is the pain is relieving by passing stools and like this.
yeah.
But I confused in two. She already diagnosed with chronic cholecystitis,
Yeah.
and the pain is aggravating by spicy food, greasy food.
Okay, fine. You are a clinician, you are a doctor. So basically, if that's why we are here. We train you to diagnose and to deal with the station of the exam. If your patient has a gallbladder problem, that doesn't mean this gallbladder problem is not accompanied by IBS.
Yeah.
Okay, that's the first point. So you have both diagnoses. The GP referred her to you as a gallbladder issue, but you should do the assessment yourself, and that's why you're taking the history. During the history, if I ask you now to diagnose as a doctor, if I came to you with this symptom and I have gallbladder, will you diagnose me from the history I said as acute cholecystitis or a gallbladder problem, or will you diagnose me with IBS? IBS. So she has the gallbladder problem, which is not active now, and it's not one of our concern. But her main issue now is the IBS. She came with the IBS. They will write in the scenario, they will tell you this patient is referred from the GP as acute cholecystitis. Even in the discharge letter from the GP, your GP may write acute cholecystitis. But when you take the history with the patient, you will come to realization that this lady has no acute cholecystitis. This lady has IBS because her history goes with the IBS. That's the most important point. You already started by asking me about the irritable question. You even asked me, does it get worse by stress? And I said yes. Acute cholecystitis doesn't get worse by stress, Umar. You already asked me about this question. I said yes. You asked me, I told you it's going. You asked me about the bloating. I said yeah, I have bloating. Acute cholecystitis is not associated with bloating. You asked me.
Confused in the last of the.
I know the scenario confused you, but that's how people fail the station. Okay. In the inflammatory bowel disease, you don't need to ask about every single question, but you ask about most of them or all of them. Skin problem, ulcer, pain in the eye. That's very good. I'm not sure if you asked about the weight loss.
I'm not asking.
Yeah. So weight loss.
In this case, I remember to ask about CA symptom, loss of weight and like this. After family history, can I get back in this case?
You can.
Yeah,
in this case, look, if it's a very important differential like a malignancy, you can. Yeah. By the way, Miss Suzanne, I just want to double check with you. Do you have any weight loss or appetite loss? By the way, Miss Suzanne, I just want to double check with you, and then you carry on. Okay. But if it was a not important differential, let's say you have 7 differential, I will give you an example of this. Let's say you have the seizure, for example, and one of your differential is hypoglycemia. You don't need to come back and ask about hypoglycemia. It's not important. But malignancy is a very important differential. Yeah. You asked about gastroenteritis also, but you didn't differentiate by asking, did you travel abroad recently? And also any air to pass stool, but little amount comes out. The differential of the gallbladder, you should ask about, does the pain go to the shoulder? Does it increase specifically by fatty meals, not juicy, fatty meals? Fatty meals. And also any yellowish of discoloration in the eye. You don't say jaundice, of course. The way you took the history is very nice. Like, I think you are not stressed, you are very calm, and you're also smooth in saying the question. You just didn't read the Skool from A to Z. If you read the Skool from A to Z, you'll understand.
I read it before 2 days, I think. I forget.
Okay, fine, that's all right. In your presentation, I think also your presentation was on the right, on okay side. It's look, your examiner has a mark for the right diagnosis, but that doesn't mean you will not lose the mark of professionalism. You will not lose the mark of
Communication.
introducing yourself. You will not, all of this mark, your examiner will give it to you. But it's very harsh when you lose that, when you miss the main diagnosis.
Yeah.
Okay? So if you got the right diagnosis, I will give you 17 or 18 out of 20. But because you missed the diagnosis, I will give you 12 or 13. So it's just harsh for the examiner to give you high mark and you miss the main diagnosis. Okay? Yeah. But your investigation, I think the treatment will be high fiber diet, stress management, antispasmodic, antidepressant. But put in mind, the same station, because people now are, that's not just for you, that's for everyone. Because people now memorize this station will be as acute cholecystitis, but the patient will take me to IBS. Everybody knows that. You come to the exam, your patient says, I have jaundice, I have pain in my right side, goes to my shoulder, and I have fever. What's your diagnosis will be in this case? Cholecystitis. Your patient says, I have mouth ulcer, I have blood coming out of my...
Inflammatory bowel disease.
Yes, exactly. So you play with the scenario. It doesn't matter which one they give to you.
But according to this case, I go to with acute cholecystitis. If any wrong in the test and type of treatment, conservative and surgical.
Are you saying if you're asking if you will lose the mark for this, or what are you saying? Can you say the question again?
يعني I'm not reach the goal of the diagnosis.
Yeah.
The main diagnosis, but
Yeah.
The diagnosis which I reached, I follow it until the end and correctly in the treatment, in the
Yes,
investigation.
Umar, you know, the mark of discussion is the 4 mark. And I know you missed the main diagnosis of this station, but just you will lose this 4 mark, or you can get 2 or 1 point from these marks because your management follow your main differential diagnosis, which is acute cholecystitis, which is the wrong answers.
Yeah.
Yeah, so the discussion, as Muhammad said, has 4 mark. You may lose the 4 mark because you give the wrong diagnosis, or your examiner may be a very kind person and give you 2 or 1.
I faced this point in my exam, Ali.
Yeah.
My patient have acute, he confused me between acute pancreatitis and acute cholecystitis. And when I jumped to the point of how to treat this patient, after the examiner asked me, I said, if the patient have acute pancreatitis, I will treat it by lab. And if he have acute cholecystitis, I will treat it by lab.
Very smart answer.
Yes, he said this point. This is a smart candidate.
Yes,
So-
exactly. Yeah, that's one of the technique. And I will tell you later on when we come to the examination also. Sometimes your patient, and this happened, I don't want to say specifically happened to whom, but in the hand examination, the lady gave the candidate 2 diagnoses: carpal tunnel syndrome and ulnar nerve injury, both of them. And then you need to do what Muhammad said. If the patient has this, I will do this. If the patient has this, I will do that.
Yeah, let me review it with Umar quickly, Ali.
Yes, okay.
Umar, very nice presentation. I'm glad that you change your tone during your history station, but increase your voice and mention the patient name a couple of times.
Okay.
Also, you should exclude your main differential diagnosis, which is IBS first. I know you exclude the IBD first. From the examination room, you will know this is IBS. So you should exclude it first before IBD. The other thing, you said no tummy pain. When you asked Ali, and it is an answer, no tummy pain. You should ask, do you have any tummy pain? Should not say no tummy pain. Do you have?
Yeah.
And
or any tummy pain, because if you said no tummy pain, that's you just telling me there's no tummy pain.
You confirm it. Yeah. The last point, when Ali asked you, you asked me this question double time. You should say, "I'm really sorry. I just want to confirm." Don't like explaining this is a recently or this is the last. because you need to take the mark of professionalism. So you should say, I'm really sorry. I just want to confirm, Mr. Ali.
So, and you will have some of the patients who are very rude. Some of the patient will come to the communication skills and will demonstrate to you. But your patient may say, doctor, you're talking too much. Doctor, you're giving me headache. Doctor, so you expect all of these from your patient. And I just want to add, Muhammad, I'm not sure if you finished, but I don't want to forget.
I finished,
one.
yes.
On your presentation, Umar, the impression you gave me, you said 33 female. Like
that's what we say.
No. The way you presented it was a bit harsh. Like you have no consideration to your patient. As we said, look, open a Skool with me now. Present your patient. It says, I took a history from Anna, a 46-year-old woman referred with chronic calculus cholecystitis. So if you put yourself in the patient candidate, I'm not talking about the exam now. Let's say you are a patient, and let's say you are my patient, and you came to me, and I don't know you are a Dr. Umar, and I took a clinical history from you, and then I came to the consultant, and you were here, and I spoke to my consultant. I say 25 male presented with. What do you think about that? Do you prefer this, or do you prefer I took a clinical history from this gentleman, 25-year-old, his name is Omar Al-Farouk, presented with da. Or I took clinical history from Umar, 25-year-old male, referred with chronic calculus cholecystitis. Which one do you prefer?
First one.
First one?
I took history from Omar Al-Farouk.
Yes. Yeah, this is the second one.
I mean that.
Yeah, so
I mean that.
Yes. So be gentle while you're presenting your patient. And as I said this point to Habiba, and I'm going to say it to you again. Your examiner may not attend how did you take the history from your patient. And the first interaction between you and your examiner is the presentation.
Yes.
That's why we need to be very careful with the presentation. Okay? If you forgot the name, I took a clinical history from this gentleman. I took clinical history from this lady. If you remember the name, I took clinical history from Anna, 35-year-old, presented with da. Okay?
Yeah, in our language, it is Sabba.
Yes. Yes. And look, I know. I'm not. Of course, you practice in Sudan more in any other country. In Sudan, while we're practicing Sudan, Egypt, or whatever, there's no consideration of the patient.
Yes.
I know.
It's totally different in UK. UK patient is the king. Patient is the king, and the issue will be if your examiner is coming from UK and you gave him a third world medicine, it will be a shock for him. Nobody says 33 female. Like you're speaking about human, and usually this human is attending with you. At least mention her name. Say a lady, 33 female. That doesn't make sense. So just say the name or say I don't have any other point. Overall, that's a good one. It's just I think you just need to remind yourself by reading the station again.
Can I have a question, please, if you got time?
Now we're gonna open the discussion. Yes.
So about the introduction, as you know here, the date of birth, we use it as identification for the patient. So there is a family name. So for example, that all of my family is going to be called Muhyiddin. And the only thing that we differentiate between the patient is the date of birth. Is going to be like normal to ask him from his name instead of from date of birth?
Yeah, that's a very good. That's a very good question. But I'm just gonna say it from a practical point of view. I know what you're saying, Muhyiddin. So usually we will come to the ward, as you know, we'll say, hello, my name is Ali, I'm one of the doctor. May I confirm your name and age or date of birth? I know age is very ambiguous. Age, you said that you may have two patients, Muhyiddin, for example, two patients with the same name. But it's very unlikely, Muhyiddin, to have
same date of birth.
two of you with name Muhyiddin, and your both age of you is 25 or 27 or whatever, and both of you in the same ward in the same hospital. That's very unlikely. Do you understand what I'm saying?
Yeah, I understand.
That's why we, to be honest, date of birth is more specific, but from practical point of view,
because the given name here is not identify the person. Even if you call to pay for any kind of bills here, they will ask you for the beginning from your date of birth.
Yes, even when the
so
nurses
it's okay.
come,
And the
yes.
other
So I just want to answer your question very clearly. Both of them are right. Age or date of birth, there's no problem with that. But for your sake and for your examination, you don't want your patient to speak too much, and you don't want your patient to give you a date of birth that you don't remember. That's why it's better for you for this exam to ask about the age. It's faster and easier. Okay? Yeah.
Any questions?
Yes, Doctor.
Yeah.
I have two questions.
Yes.
The first one, you was talking about the cholecystitis, acute cholecystitis. You
Yeah.
said pain and jaundice and fever. So how can I differentiate between acute cholecystitis and ascending cholangitis in the history?
The fever.
Both have fever.
No, acute cholecystitis less likely to have a fever. Pain and
Yeah.
vomiting.
So yes, we have a general surgeon here. Remind me of the triad and the Ronald.
Charcot triad. When
Fever,
involving fever,
jaundice,
it will be yes,
and
fever,
pain.
jaundice, and pain. This is Charcot triad for cholangitis, يعني infection. Cholecystitis less likely to have a fever.
Yes.
Yeah, as appendicitis, very rare came with significant fever.
Okay. Do you remember Fatah Rahman? Do you remember Ronald's Bentat?
Yes, this is with I think we'll add sepsis, significant sepsis.
Yes. Which with the patient will have Charcot plus hypotension.
Yes, hypotension and sepsis symptoms.
Yes. Habiba. So your patient, if he has acute cholecystitis, to be honest, he will say you can consider ascending cholangitis as a complication of acute cholecystitis.
Yes.
It's just like a severe form of the acute cholecystitis.
Yeah, Ali, also the sign of
even,
very adhered to the right shoulder.
Yes, ascending cholangitis, they will have Shiva, right, Muhammad? From what I remember.
Yes, Shiva, and it comes as a complication.
Yes.
They will have rigors, right? The ascending cholangitis.
Yeah, and it comes as complication, Ali.
So on your exam, they will not ask you to differentiate between acute cholecystitis or ascending cholangitis.
Yes.
100. Even a consultant will find it difficult. There's no way. It's going to be 99.9% is going to be referred to you as IBS, as acute cholecystitis, and you will discover it as IBS.
Yeah.
If they try to act smart and change the scenario, they will refer it as, because everyone is not, it will learn how everyone here is memorizing, the station will be IBS, right? They will let the patient say, I have jaundice, I have some fever, and I have pain around here, to return it to the same diagnosis, which is acute cholecystitis. That's the maximum they can do.
The other question?
Yeah.
I guess I want to ask
she said she has two questions. What's the second one, Habiba?
Okay, the other question, when I was taking the history about back pain, I said, do you have any problem in bowel movement control? And urinary control. Is these words easy for the patient to understand, or it's more medical words?
I would prefer. Okay, I'm going to make it easier for you. So we ask about. We have every day. We have multiple back pain referral, and in all of them we need to exclude the code equine, unfortunately, which is very boring. You can say, Mr. John, I just want to check with you. Do you have any bowel or urinary incontinence? You can say incontinence because incontinence is a
Layman.
layman, yeah. So you can say incontinence.
Okay.
Or a different way. How do you have? Are
Any
you
problem
able
with
to
urination? Yeah.
Yes. Are you able to control your urine and your stool? But the word incontinence is fine. Okay.
Okay. Thank you.
Yeah.
Thank you.
Other question, please.
Someone wanted to ask a question.
I have some point for Umar.
Yes, please, Rahman.
Yes. Umar, good thing that you are very calm, as Ali mentioned, and this is what we need to reach it by myself also during the presentation. But initially, you ask the patient permission to be his doctor or her doctor. You don't need to ask to be her doctor. The permission for the question or conversation. You said,
Okay.
I will be your doctor today. Is that okay? She has no right to reject you unless she mentioned, I don't want you. But the permission for I would like to ask you a few questions. Is that okay with you?
Yeah, a nice
This one.
point, Fatah Rahman. Very nice point.
Yes.
Okay.
And for the sorting out the differential diagnosis, you are mixing between multiple symptoms for multiple differential diagnosis.
Mm-mm.
You need to.
Because I'm not read the topic. I'm
I'm
just
coming. I'm coming
practicing.
for you. I'm coming for
Yeah.
you.
That's fine. Yeah. So
what I'm getting from medicoplasty, you need to put sub of scheme, regardless the scenario is what.
Yeah.
Mm.
If you follow, you will not miss anything.
Yes,
Yeah,
that's why we ask everyone to study from the material
Yes.
because it will
Yeah.
be even for you guys later on. If you want to practice with each other, you will have a unified resource. That's our main goal. Our main goal from school, and it's like one resource, so all of you can return back to it. It's not like everyone is studying from a different resource.
Yes. Yes.
Yeah,
Yeah.
and we know that.
Another things.
Yeah.
Excellent intervention or interaction from you, Ali, regarding why you don't you don't want to remove my gallstone. If I don't know what to answer, I have a very smart thing to say to the patient.
Yeah.
No worry, Ms. Suzanne. I will discuss this issue with my consultant and
I
update
will
you.
update you. Yes, excellent, Fatah.
Yes,
Just escape.
Yes, be diplomatic. I tried to make the station more difficult for Omar.
Yes. This is what will happen in his exam. Exactly.
Yes, his performance was very good, and I just tried to make it, and I saw him very calm. So I said, let's irritate him more. Let's say, give him a bit of a trouble, and I think he acted okay. But I think the better way is to say, yeah, we will discuss this later on with my consultant, and we'll figure a plan for it.
Yes.
Yeah.
Another thing.
Yeah.
I'm sure, Umar, you are putting the differential diagnosis in your head, in your thinking. Regardless what you are get from the spot diagnosis, the general management, it will be almost same for investigation, approaching, and lab work. It will be almost common. Just do it for all differential. Don't focus on I will investigate for cholecystitis.
Yes.
Dr. Ali.
Good. Thank you, Fatah Rahman. That's very good. Yeah.
Yes.
Yeah.
So this will minimize, will reduce the number of degrees that will use. It will be all specific for treatment.
Yeah.
Yeah.
Yes.
Good.
Yeah.
Akasha?
In this point, doctor.
Yeah.
In this point, يعني when he said what the treatment, can I just say conservative and surgical without details? If he,
No, you have
until he asked,
No.
you have to mention the details.
Yes.
But all the conservative consists of analgesia,
Analgesia, hydration, and all that
lifestyle,
thing.
hydration. It's just about
Yeah. Ali,
the way you
I
say.
gave him the answer. You should say, if I suspect acute
Yeah.
cholecystitis, I will treat it by lab. If I suspect IBS, I will treat it by lab.
All right, Akasha. I need to Akasha. You want to say something?
Yeah, the last.
Thank you, Fatah Rahman. Thank you,
Thank
Omar.
you,
That's
Fatah
very-
Rahman. Thank you,
Yes,
Omar.
yes, thank you.
Yeah, Akasha. What do you want to say?
Yeah.
Akasha.
I
He
think
wanted to say
muted himself.
something, but I lost. Okay,
You can
Muhammad,
drop his question in the Telegram group.
yeah, and this station also will be uploaded later on. Please review your